I'm Stephen Bezruchka, and thank you all for coming. This session is called Declining U.S. Health, a Population Health Emergency, and I'm really thankful to APHA for allowing us to present this material. Now, our theme this year is creating the healthiest nation, overcoming social and ethical challenges. And I'm hoping that we can address some of those here. So I'm going to introduce the panelists, and then I'm going to ask each of them a question, and then I'll ask the other panelists at the end of the 4 questions to respond, and then we'll take questions from the audience before we go on to other material. So, Mary Bassett is director of the Francis Xavier Bagnot Center for Human Rights at Harvard and a professor in the School of Public Health there. Sandro Galea is the dean of the Boston University School of Public Health. Donald Warne is the co-director and provost fellow at the Johns Hopkins School of Public Health for Indigenous Health. And finally, Stephen Woolf is from the Center for Society and Health at Virginia Commonwealth University. So I'm going to ask the first question of Stephen Woolf, and I remember this well. 10 years ago in January, I think it was January 8th, the Institute of Medicine released a report with the title U.S. Health in International Perspective, Shorter Lives, Poorer Health. I tell my students to always craft a title that says everything, and I think this is a very good example. It got a large entry in the New York Times the next day, and the lead editorial, back when the New York Times had an editorial page, the following day. And we're now more than a decade out since then. So can you talk about what's happened since the release of that report and why?
Well, it's not a happy story. At the time that the report came out, and I had the honor of chairing that committee, we documented that the United States was doing worse than other high-income countries on dozens of health metrics. Life expectancy being one of them, but mortality rates from multiple causes. The prevalence rate for diseases was higher than in other countries. And it was multi-systems, so much so that you could not blame it on a single cause. It was clear that there was a systemic origin for the problem. After that report came out, we started experiencing a flat line in our life expectancy. Life expectancy has been climbing in industrialized countries for the past century. Back in the 1980s, the pace at which the U.S. life expectancy was increasing began to fall off relative to other countries. And at the time our report came out, it was actually stalling completely. So the gap in life expectancy between the United States and peer countries began widening very dramatically over that decade after 2010. One of the driving forces was an increase in working age mortality. This is deaths among adults 25 to 64 years old. 4 main causes for that: drug overdose deaths, alcohol-related disease, suicides, and cardiometabolic disease were the main drivers for that trend. And so the gap widened considerably, and then we rolled right into the COVID-19 pandemic. And all of the systemic problems that our report discussed and that really were never addressed continued right into the pandemic, and we saw the manifestations of that. Yes, there were policy mistakes that were made in handling the pandemic, needless to say, a bit of an understatement. But the core issues that were already responsible for the U.S. falling behind led us to have one of the largest drops in life expectancy in the industrialized world. And the inequities that we have in our society, the systemic racism and the stark racial, ethnic, and socioeconomic inequalities that predated the COVID-19 pandemic were clearly on view, where we had a loss of 3 to 4 years in life expectancy in the Hispanic, Black, and Native American populations. So not a very cheerful story.
So let me just follow on to that. A life expectancy gap, say for, I coined the term health Olympics many years ago. So if health was an Olympic event and the race was how long you lived, life expectancy, with the most recent UNDP report published last year for data in 2021, we're almost 8 life expectancy years behind the longest lived country, Japan. And most of us don't have a way of evaluating those 8 years. Does it just mean another few more years drooling in a nursing home, or what does it really represent? Well, one calculation would say that if we eradicated in 2021 our 3 leading disease killers, heart disease followed by cancer followed by COVID, we'd gain about 7.5 years in life expectancy. So I would offer that that's a big gap. Mary, you were New York City Health Commissioner and reported in a 2015 article in the New England Journal on Black Lives Matter about black women in New York City having maternal mortality 10 times higher than that of whites. So African American outcomes are much worse, and for maternal mortality, even for college graduates, black women, college graduates, maternal mortality is higher than for any other racialized group in this country of any educational status. Can you speak to racism being the fundamental cause of these health inequities?
Thanks, Steve. That's a really big question. And I want to go a little bit off topic to say something about the Institute of Medicine report that Steve spoke about, and really urge the audience to take a look at that report from 2013. It was not given the kind of attention it should have received. And my favorite graph from it, and I know Sandro has another favorite graph from it, is of the mortality rates of non-Hispanic whites, people we call white people, ranked order by age group as compared to peer nations. These were mostly Western European nations. What it showed is that for whites, the rates were at or near the bottom. The U.S. ranked at or near the bottom until you got towards the end of life, like age 70 or so, where that's when the U.S. began to perform better than its peers. That's not when all of us want to protect our life expectancy. We want to protect our life expectancy among children and young adults and working age people. But it also importantly showed that this argument that the problem with U.S. Life expectancy statistics and mortality rates was its minoritized population. That if the U.S. looked more like Switzerland, or if we only considered the life expectancies of white people, we'd be doing okay. And what this report made very clear was that we would not be doing okay. So in 2014, I was stunned to see the maternal mortality rate of black women in New York 12 times actually higher than that of white women, and a high school dropout, a white high school dropout, had a lower maternal mortality rate than a college-educated black woman. This followed on a very well-known study that showed higher rates of preterm birth among college-educated black women. And this, to me, really underscored the enduring impact of race in this country. And I think of racism as operating as antecedent to what we call the social determinants of health. That means just about anything that you can think of, which we call today a social determinant of health, is going to be stratified by race. So that access to decent housing, a decent job, high quality schools, high quality health care. All of these in our country are stratified by race. And of course, access to health care has an important impact on the ability to survive a pregnancy and delivery. But of course, that's not all that you need. You need healthy women to start out. And in that, the US has been failing. So not only were we failing to ensure dignified, appropriate health care for women presenting to hospital when pregnant, who are African American, we also haven't done enough to ensure that women are healthy before they become pregnant. And both of those are driving our maternal mortality rates. Now, the gap is not as big. I know we have 90 minutes, so I'm just going to keep going if that's okay. The gap that we have today nationally is not that big. It's about, but it's still, Black women have the highest maternal mortality rates as compared to women who are classified as white or Hispanic. I'm sure that Indigenous women have very high maternal mortality rates, and maybe Don will speak to that. But the most recent data presented by the CDC only gives data for these three racial ethnic groups. And it remains true that Black women have about 2.5-fold higher risk of dying either during pregnancy or in the first 42 days after terminating a pregnancy. And that risk, I would say, belongs both to the well-being of the woman and the ability of a healthcare system to take care of her. And the most important thing about this recent CDC report is that we're seeing an increase in maternal mortality rates across all groups. So, and we're seeing also, we may come to this later in the discussion, we're also seeing an increase in infant deaths. Now, there are not that many women who die related to pregnancy and are defined as having a maternal mortality. I think the number in 2021 was about 1,200. I don't know how many people die every year in the United States, but it's in the millions. But obviously, the death of a mother while pregnant or after delivering is a very socially costly death. It's not only that she's died, she may leave children or an infant, family. The representation of that to a whole community means that these deaths are ones that we consider particularly harmful to us all. So that's what I think about maternal mortality. It's sort of a canary in a coal mine kind of indicator.
Thank you. As Mary was talking, I was reminded of a lecture I attended as a medical student at Stanford on March 31st, 1971.
Well,
I pitched most of my notes except for this particular course. And in that first day's lecture, I wrote, in 1951-53, the United States had the lowest maternal mortality of all countries. And I remember the number, it was 61.3. I then wrote further down, by 1966, about 9 or 10 countries had done better than the United States. If we look at Black maternal mortality with the latest report in the United States, it's 69.
right.
So we have exceeded the best outcomes in the world that we had here in the United States in 1951-53. I scanned my notes and I show this when I present this material to students in class. So something serious has gone wrong.
Very serious.
Yeah.
That's why I'm really glad to see so many people here. This is very serious. Yeah.
So Donald, you were born and raised on Pine Ridge Indian Reservation in South Dakota, where there's the lowest life expectancy in the country. It's also faced the greatest decline in life expectancy over the last few decades. How do you explain this outcome, and what has been the public health response?
Yeah.
Anpetu washte hau pilami ayalo. So, hello and thank you to all my relatives here today. Very honored to be a part of these important discussions, and I appreciate having an Indigenous voice at the table and an opportunity to share some thoughts. And unfortunately, you're correct. Where I'm from, we have a terribly low life expectancy. We collect data both on life expectancy at birth, but also median age at death. And for men from Pine Ridge, the median age at death is in the late 40s. So most of our population is not even reaching age 50. So, you know, the way I responded, I'm 57. I guess it's all gravy from here, right? I've exceeded the life expectancy. So it's really unfortunate. And in many ways, we have third world health conditions. And I like to remind my friends in academic public health that you do not have to cross an ocean to find third world health conditions. It's right here in the U.S., in the heartland, and certainly in reservations, particularly in the Great Plains. So why are the disparities so terrible? And we're about to publish some data out of North Dakota that's very similar to the patterns that we see in South Dakota. For the decade prior to the pandemic, so 2009 through 2019, the median age at death for American Indians was 58, and the median age at death for the white population was 79, so 21 years different in the state of North Dakota. But for men, it's even worse. Median age at death for the entire state of North Dakota for American Indian men is 55. This is pre-pandemic. And actually for white women, 85. So in many ways, it's a blue zone for white women in the same state where men are dying, American Indian men are dying by age 55. It's just really remarkable. So when we take a deeper dive into the data, the disparities are across the board. We have much higher infant mortality rates, about 5 times greater infant mortality rates. We also see greater rates of death due to injuries, largely, of course, unintentional injuries for the younger population. But then we see other issues related to despair, things like suicide. Our suicide rates among young people are just tremendously high. And then, unfortunately, we have chronic disease at a much younger age. I remember many years ago, I used to work for NIDDK, National Institute of Diabetes and Digestive and Kidney Disorders, and doing diabetes research with American Indians. And that's when we had to change the terminology from adult onset to type 2, because we were diagnosing adult onset diabetes in 6-year-old American Indians. And that pattern still remains the same. So there's hardly a measure of disparity in which we don't see worse outcomes for American Indians, particularly in the Northern Great Plains. And I really like how Mary framed it, that at the base of a lot of what we call social determinants of health is racism and marginalization. And if we just look at the history of American Indian populations, I think it's important to remember that this is indigenous land. You know, this is the land of indigenous peoples. And there were policies that were intended to separate American Indian from their homeland and from their food systems, from culture and language, the boarding school systems. There's just a long history of racist policies that have had an intergenerational impact. There's a law even called the Indian Removal Act from 1830. Think about that, the Indian Removal Act. And the law was basically to remove American Indians from right here in Georgia and in the southeast into what we now call Oklahoma. So in that process, people lose culture, cultural practices, sacred sites, language, food systems, and then become dependent on federal programs that have been largely underfunded and inadequate. So we have the perfect storm of policy history that leads to disparities, along with intergenerational poverty and challenges related to other social determinants of health. But within all of that, when we look at indigenous health and indigenous determinants of health, we also have a lot of strengths. And it's remarkable that we have our people here at all, right? It speaks to the strengths of the cultures and to the peoples. And our newer research is showing that things like cultural connectedness, language preservation, and participation in traditional ceremony are protective of health. So I think part of our challenge moving forward is that, yes, we need to understand the disparities, but even more importantly, we need locally generated and culturally relevant solutions to reverse the disparities.
So to make a generalization, non-Indigenous people speak of their rights. And if I'm correct in assuming this, Indigenous people speak of their obligations. Yeah. It's a very different perspective on life. Does that make sense?
Absolutely, and I think one of the bigger cultural differences, at least what I observe, is that we have much more of a communitarian perspective from a traditional Indigenous lens, and recognizing that the health of everyone in our population is valuable, and that the well-being of our neighbors has an impact on our own well-being. And I think there's less of the individualistic perspective and much more of a community-based perspective. And really that is at the root of what we should be doing in public health anyway. I think that public health has much to learn from Indigenous perspectives and cultures and voices. And just think about what we're doing now in public health. I wish we would do some things a little bit better. So for example, having the maternal mortality report excluding American Indians is a huge mistake, right? So we're still here. And as Indigenous Americans, we should be at least a part of the database, right? I mean, that's a very simple, low bar to cross, just to be included in the data. So I think when we look at this from a communitarian perspective and the idea that we are responsible for each other, not just for ourselves, that then addressing these things is more of an obligation. It's what we are supposed to do as good human beings. And we don't believe that we own the earth and its resources. We're stewards of it for future generations. And if future generations are going to be healthy, we need to take a hard look at what we're doing in public health and improve upon it.
So, Sandro, Galea, what can we do from a School of Public Health perspective to make sure that the next generation of public health professionals and workers center around making Americans aware of their health status, that we are dead first, and what can schools of public health do to further improving our health to do a lot better in the Health Olympics?
Well, first of all, thank you for arranging this, Stephen, and thank you to my colleagues. It's really an honor to be here with you and with you all. I'm going to use the question as an excuse to make a few other points that reflect what my colleagues have said, because I will answer the question by saying, I think the first thing we can do is be clear about what these things mean for the larger population. So let me start with reflecting a little bit what Dawn and Steve and Mary said. Number one, Mary alluded to the fact that I have a different favorite graph in the report that Steve chaired. And the graph that I really like in that report shows that we as a country do better than other high-income countries when we're over age 75. And we do worse all the way under age 75. And the reason I like that graph is because it makes the point clearly, which I think we have been poor at making, that the reason for everything we're talking about is not about healthcare. The reflex in this country has been, and it hasn't always been, in the past sort of 50 years, that yes, we realize that health is poor. As a result, we should invest in healthcare. And I think recognizing that the drivers of everything we're talking about is not healthcare should be something that's much sharper in our minds and should be sharper in people's minds. And it is our job to make that point clearly. And it emerged implicitly from what everybody said, but I think we should be explicit about it, that ultimately the solution to this is a non-healthcare solution. So I think that's point A. Point B is we have to get better at articulating how these forces we're talking about harm us all. Now, harm us all unevenly, but they harm us all. To pick on Mary's example, maternal mortality, for example, maternal mortality among black women is any number of factors, about 10-fold higher than it is among women in other high-income countries. But in analyses that have been done restricting maternal mortality to white women in the richest 1% of counties in the US, that group still has maternal mortality twice as high in other high-income countries. Another data point is when you look at our health across all percentiles of income, so like from the lowest 99% to the top richest 1%, we actually have worse health outcomes than all other high-income countries. So these issues affect some of us more than others, but they affect all of us. And I think that's actually a very compelling perspective because it can bring people along to recognize that we are hurting everybody's health, not just a particular group. So number one is being clear it's not about healthcare. Number two is that it's affecting everybody's health. Number three is that it doesn't have to be like this. And Stephen, you actually prefaced this by saying, well, 50 years ago, 60 years ago, actually, we were ahead of other high-income countries in health. And then we no longer are. In fact, when you look at Steve's report and other data, there was a turning point in sort of in the 80s somewhere, where our health went from being among the best in the world to being certainly worse than all other high-income countries. And recognizing that it doesn't have to be like this, it wasn't always like this, means there are things that can be done. Because I think otherwise a certain fatalism sinks in. You know, and I think, you know, Don, when you talk about some of these data in among Indigenous Americans, there's almost a helplessness. It's like, well, this is terrible. It's been terrible for such a long time. What else can we do? But I think it's very important that we actually give the narrative that this is a result of choices. It's a result of policy and economic choices. And as a result, we can make different choices that create health for all. So number one, I think we're clear that's not about healthcare. Number two is it affects all of us. And number three is that we can actually reverse a lot of these things. History has shown us we can do it. So I think making those 3 points then brings us to the next generation. The good news is the next generation is fabulous. The next generation of public health professionals are smarter and more committed than we are. It is, you know, I see them every day. It's a great privilege to be in a school of public health where I see the next generation. So I think our job is to lead with these points, is to put this front and center in front of students. And we try to do that in our school. Many other schools do it as well, where students, we recruit students who recognize that this is a problem, recognize that this is something that should be tackled. We encourage them to make this front and center in what they do, and we encourage them to go out into the world committed to creating solutions. And, you know, there's plenty of reason for pessimism, but I prefer to lean into optimism and to say that the next generation will do better than our generation has done on these issues. Now we need to give them the tools, the intellectual tools, and the policy and political tools to get there. But I would like to lean into the fact that the next generation is going to move us towards solutions that have eluded us for the past 50 years.
So one of the question I originally was going to address with Sandro was there's a committee on education criteria in public health schools, and I in an informal survey found a lot of students in public health schools. The fact that our health status is so poor is mostly not addressed in courses. The Council on Accreditation of Schools of Public Health does not have a criteria comparing U.S. schools, U.S. public health with other countries. The only comparison stated in criteria there are looking within the United States. So I'm told from trying to address broader criteria that the next meetings will be in 2026, and perhaps that can be addressed then. So I think most schools of public health don't do what they could be doing to present this information in a broader format. Well, I said I would ask for audience questions. Well, no, I said first said I'd ask the rest of you to respond to what has been said, but I even forgot to mention at the very beginning a potential conflict of interest I have. I've written a book with the title "Inequality Kills Us All," and there are flyers for that book offering a discount that were at the entrances, and so I'm sorry for not addressing this conflict of interest or potential conflict, but the title, I think, says it all. We're all affected. We can't say that what we're talking about here doesn't affect all of us. So please now respond to each other.
Should Steve go first?
Well, one of the things I was reflecting on as I listened to my colleagues talking is, and each of them said this, but it bears repeating, this didn't happen by accident. These conditions exist because of a history, a long history that goes back hundreds of years, and that carries with it intergenerational consequences that we live with today. Much of the data that we've talked about is cross-sectional data that's looking at how things are right now, but it's really important to understand that policy choices got us to where we are. In a recent study we documented close to 60 countries that have outperformed the United States on life expectancy, and of those, 17 of them have outperformed the U.S. for 50 years. So they've figured out how to protect the health of their population. So it's inconceivable that the wealthiest country in the world, with all the resources that we have, can't figure it out. What we lack is not solutions, but political incentive, political will to take the choices that we know would be effective in addressing those health problems.
If I can go back to Sandro and what produces health and the limitations of healthcare, he was the last author on a paper published last year that looked at internet surveys of people's perspectives on health production in 8 countries, including the United States and Germany. And they were asked to rank 8 items from healthcare down to politics. Well, it wasn't in that order necessarily, but all of people in all of the countries, the highest ranking was for, in terms of producing healthcare, and the lowest ranking was for politics. Now, the ancient Greeks knew that that politics was a very important aspect of the production of health. Rudolf Virchow in 1848 said all diseases have 2 causes, one biological and the other political. So somehow people's perceptions on what produces health appear to be entirely backwards.
Yeah, I can comment on this work led by my good colleague Salma Abdallah, and we've actually done that work both domestically and globally, and where we ask people, what do you think matters most for your health, and you can rank it. And we found in the US and globally, it's pretty consistent that people rank healthcare as the most important factor and politics last. That was, of course, interesting because this conversation would, if I were to fill that survey, I would say politics is the most important aspect that determines our health. And I think what that speaks to is the difficulty of shifting the conversation. That unless, until the prototypical average person, whatever that is, around the kitchen table, they're discussing how politics affects their health, it will be harder for us to push through the kind of social policy, political, economic changes needed to improve health. As long as we keep believing that if I only have a better doctor, if I only have a better test, if I only have a better drug, then my health is going to be okay. Like, we need to sort of shift beyond that. Now, we need to be careful because I think in public health sometimes we make the mistake of creating either-or arguments, and that doesn't help us at all. We have to be very clear, and in some of my writing I've used metaphors to try to explain that healthcare matters. Healthcare is important. We want to have a good healthcare provider, but it's only one part and a small part of a much larger picture. And I think it's on us to tell that story.
So I tell my students, when you use the word health, ask whether you really mean healthcare. Just think of the phrases we use. We access health, pay for health, get health, insure health. It's nothing of the kind. It's healthcare. We access healthcare, pay for healthcare, get healthcare. So the real question is, do you want health or healthcare? And nobody asked that question in this country. Any other comments from the rest of you?
Sure. Should we go in order, Steve, or how would you like to do this? Okay. Well, I have to say one thing that I was reflecting on, and I really appreciate being part of this conversation and all the comments made by you and my fellow panelists, is that we have to also acknowledge our history. That we have a history in this country of 400 years of 250 years of enslavement, followed by Jim Crow and continued discrimination against people of African descent. We have a country that was founded and generated its wealth with the labor of enslaved Africans on the land taken from indigenous people, whose numbers today reflect the genocidal campaigns that were waged against them to appropriate the land. So this has to be part of how we think about our current health today. It didn't just start in this century or in the 20th century. A friend of mine at Harvard, Evelyn Hammonds, points out that there's not been a single year since vital statistics have been collected in the United States or even in colonial times, that people of African descent haven't been sicker and died at younger ages than people who are classified as white. And we probably don't even have the data to make an equivalent comment on people of indigenous descent. So there have been terrible harms done that need to be addressed in a way that has to be more robust and muscular than anything that we've done so far in my working life. At the same time, when you look at any of the graphs, something happened in the 1980s. That's when you see the United States really begin drifting away from its peer nations. That's when you see the avoidable desks or avertible desks beginning to pile up. And we have to say, well, what happened in the 1980s? And I would say to this audience that what happened was the introduction of market fundamentalism as an organizing force in American political life that affected how we organize our health care and how we organize all aspects of life. So this is not going to be solved by technical solutions alone. This is going to have to take a recommitment to the value of life and healthy life over the value of profit. And that's going to take social movements. So what I say to my students, now that I have them, to the staff who worked in health departments when I had the privilege of being a health commissioner, is get involved in anything that you're passionate about. If it's the climate crisis or homelessness or access to affordable housing or safety, anything that you look at, you'll find that the impact of privatization and can be found. And working on any of these issues, I think, will take us all to social movements. I really think that we need to get rid of the idea that to say these sorts of things is getting political, except in the Greek sense of getting political. This is part of our obligation as people who want to defend health. So I don't think that the argument that this affects us all and affects some of us more damagingly than others really captures the extent of the harms that have been done. That's why I think we should start talking about reparations, for example. But at the same time, it would be naive to think that a system that was put in place to marginalize people wouldn't begin to affect everyone. And that's exactly what we've seen. I mean, do people realize how frightening it is to see a nation like this one, the wealthiest in the world, experiencing declines in life expectancy? And as Sandro has said, this is across the income distribution, except at the very highest end. It's across racial ethnic groups. It's across geographies, even though there are variations. So, you know, this is big, and it's going to require all of us to get busy and involved. That was a speech, I think. So I'll turn it over to you, Don.
Yeah, and I agree that we really do need a social movement to move in this direction and to get to a point where we can eliminate inequities. And part of that social movement is the workforce. You know, the next generation of our workforce really needs to be, I think, better informed of some of these challenges. And I look at, for example, with American Indian, Alaska Native populations, can anyone guess how many deans of medical schools in the U.S. are American Indian? Zero. Yeah. And how many deans of public health schools are American Indian? So we're not just underrepresented, we are unrepresented in this space. And that needs to be solved. I mean, here it's 2023, this is ridiculous. And I think the challenge historically within health systems academics is that quite often we just don't know what we don't know, and lack of diversity among leadership and those who are actually developing curricula results in curricula that do not include American Indian or other indigenous voices. And it's remarkable to me that you can get a Master of Public Health in the United States and not understand the legal basis of the Indian Health Service. That's not even part of the typical curriculum. So in my own career, I complained about it a long time, but decided to do something about it. So we established an American Indian Public Health specialization at North Dakota State University for the MPH. And I'm really happy to report we're in our 4th cohort of the Indigenous Health PhD at University of North Dakota. We've matriculated 60 students, of which 55 are Indigenous people, into that PhD program to actually understand these issues at a deeper level. But it shouldn't just occur in North Dakota, right? And perhaps part of our work now is with council on linkages or similar prospects and recognize that this is a broader issue, and it shouldn't just be resolved in one small state where we're seeing terrible disparities. That if we genuinely want to make that social movement effective, then the next generation of our workforce really needs to understand these things at a much deeper level. And that's, I think, incumbent on all of us to be a part of that movement.
Thank you. Any other comments before we take our first question?
Yeah, just one quick one, and then I'd love to hear from the audience. Again, I hate to be the bearer of bad tidings, but things are actually worse than we've described. So it used to be that I talked about this increase in working age mortality, but had a bit of good news, which is what Sandro mentioned, that among older Americans, we're doing better than people in other countries. And on the opposite age spectrum, young people, that we were continuing to see mortality rates fall. Well, COVID-19 brought an end to the advantage we have in the older population. It's no longer the case that older Americans are doing better than older Americans in other countries. But now, perhaps the most alarming finding I've seen in my career is that pediatric all-cause mortality rates are now climbing. So this is from age 1 to 19. We have seen an increase in pediatric mortality rates on a level that we haven't seen in at least a half a century. Led a lot by homicide, suicide, drug overdoses, and more recently car accidents, all external causes of death. So what this basically means when we're saying that all-cause mortality is increasing, it means that those 4 causes of death are outweighing all the advances we've made in treating pediatric malignancies, in preventing injury deaths from multiple causes. Tremendous progress that's been made in preventive pediatrics over the last few decades. All of that is now being offset by guns, bullets, cars, and drugs. So I think that, you know, we clearly have a problem, but my concern about how we're going to move forward is we all have to, as a society, agree that we have a problem. And I'm not sure we're all there yet. We've already established, we might like to think that everybody understands that health is about more than health care, but we've established that's not the case. We'd like to think that we all can recognize the history of our country and the role of systemic racism, but in our society, that's not the case. And on we can go. We need to agree on a core set of facts, and one of them is that health is the most important, that this crisis is the most important goal for us. And I think that's a contested premise in our society. We in this room see health as a tremendous priority, but there are corporate executives and people in ideological camps who might say they're willing to live a shorter life in order to obtain the gains that they consider more important. And until we can get around that problem, I'm not sure we're going to get the political incentive to really achieve social change. There's a lot of people at the microphone, so we should hear from the audience.
But you didn't mention infant mortality has also gone up.
Yep.
So it's, yeah.
Well, I could follow on to that, but I see a couple of people over there by the microphone wanting to ask a question. So please.
Oh, yeah. My name is it on now?
Yeah.
My name is Ed Anselm. I'm from New York, and thank you very much for your depressing yet ultimately empowering presentations and discussion. The thing I'm passionate about is tobacco control and tobacco cessation. We, as many of you suggest in your comments, we know the kinds of things we need to do, yet we don't seem to fully implement the knowledge. The thing I've observed most recently, and many of you are aware of, is this regional variation in the prevalence of tobacco among youth, among adults, and that of course correlates with its morbidity, tobacco-related morbidity and mortality. So I want to know, in the context of the larger things that can be attained, what can be done at a local level to put better, to put what we know works in practice to more systemic effect? Thank you.
Well, I have a stock answer to that, but I'll defer first.
I'm not sure if the question was about the importance of tobacco control, and of course tobacco remains a leading cause of preventable mortality. I was the health commissioner in New York City, which pioneered a rapid decline in the prevalence of tobacco use in adults from 20% down to 12% in less than 8 years. But the barriers are partly this strongly held belief that people have the right to choose their poisons, and that if they want to smoke, that they should be able to do that. And another part of it is the successful lobbying of the tobacco companies and their extension of nicotine addiction to new products. So it's a combination. I think, the best approach that we saw in New York was regulatory and not educational. So just telling people things that they should, and imploring them to improve their health when all around them unhealthy choices are quite easy to make, is never going to be enough. And we really have to support regulatory powers of government, which are rapidly being stripped. So, well, did you have a more direct action idea than that, Steve?
Well, I was an emergency physician for 30 years, and a lot of smokers I had to deal with about, their smoking habits and what it did to their health. And I would harangue the smokers about them. I would blame them. And then I learned that the longest lived country in the world, Japan, has more than 3 times the proportion of men smoking as in the United States. 3 times as many men smoke per capita in Japan than in the United States, and they're much healthier than we are. So I had to think differently. I had to sort of question my beliefs about personal behaviors, and I came to realize that the context in which you smoke, the country in which you smoke, is the reason tobacco harms much more than whether you smoke or not. And this is based on quite a few research studies. And I tell my students, Japan breaks all the public health rules. Women don't smoke much in Japan, but if they smoke, they do it when they're pregnant. And their maternal outcomes are among the best in the world. So I urge you to look at these absolutely crazy ideas and reconsider. Changing your mind is one of the best ways of discovering whether you still have one or not.
Can we go back and forth between the two microphones?
Yes, over here, please.
Okay, thank you. I come from a public health family. My father was part of the smallpox eradication program. I have my MPH and my DRPH. And what I'm hearing you talk about is science and politics. But I want to say that science unmarried to culture is irrelevant. That I have focused on health promotion and disease prevention for more than 40 years. I'm retired now, thank the good Lord. And I can tell you that our schools of public health are not paying attention. I don't mean all of them, but I worked at the Mailman School and I worked at BU. And I can tell you that the dirty secret in public health is that you can create the most informative information. You can spend hundreds of thousands of dollars on perfect media presentation. People might show up if you're lucky. And if they do show up, it doesn't change any health behavior. Why? Because we don't engage the community. We don't engage the grassroots. By working to putting our degrees in our pocketbooks. Don't leave them at your desk. Put them in your pocketbook. You have them, but you communicate with human beings about human stories, and you share human stories with each other. You build trust with the community that you want to work in, and you will be surprised what kinds of changes can emerge after spending several years engaging the community that you care about and you want to work with. And I just wanted to make that statement. Thank you.
Thank you.
So I think culture is one of the most important factors in producing health, and it's the least studied in Sandro Galea's macro social determinants of health. He has a chapter by Eckersley from Australia on culture, and I use that all the time. Think about culture as being the part of the explanation for why Japanese men can smoke and not pay the same price we do. The answer is culture, or the Japanese concept of wa, or social harmony. Do you ever see a lone Japanese tourist? Do you ever see a lone American tourist? All the time. They do things together. It's part of their culture, and that can assuage a lot of personal behaviors that we think matter much more.
Yeah, just a quick response. I know we have a lot of questions and comments from the audience, but just I appreciate the comment, and what it makes me think about is the whole idea of evidence-based practices, and it's important to understand those evidence-based practices. But my question is always, whose evidence is it? You know, where is that being created? And without a cultural and local context, is it really applicable? So in Canada, they're a few steps ahead of us. They're doing what they call wise practices, and recognizing that if there is an evidence base, it needs to be adapted to local culture, local language, and local norms. Otherwise, it's not going to be effective.
And if I could just say the most important part of that comment, I think, is the notion of connecting with communities. And the communities that are bearing the brunt of a unhealthy environment, we have to believe that these are communities that care about their health and understand how they view the kinds of things that we're proposing as policy interventions or programs, that they have the right to question them, that they have the right to give us their input when we're in the position of implementing programs. And so that's why it's really sort of two columns. One is community involvement, engagement, participation, however you want to frame it, and the other is promoting a policy environment that's supportive of public health.
Next question, please.
I like that phrase, wise practices.
This question is coming from a place of what I would call political realism. One of the major obstacles to achieving the goals that you all have advocated is this deep political divide where we're almost exactly 50-50 on the fence between what to do with these things. Is there, I'd love to hear what your ideas are for strategies to win over and change that when it seems like what you're advocating makes so much sense.
It's a good one for Sandro.
Well, I can try that. I think it's very important. You know, one of my favorite definitions of public health is that public health is an aspiration rather than a profession. It's something that we aspire to. We aspire to the healthiest population possible, all of us. I think it's very important to have a radical vision for what that looks like. It is a world where we live as long as we can, as healthy as we can, and by we, I mean all of us, every single one of us. That is the aspiration. the question is, how do we get there? And I think the question for us in public health, in organized public health, which is roughly what this is how one gets there, how one achieves a radical vision, and including as many people as possible along for the ride in that radical vision. And I think sometimes there is a danger in having a radical vision in not being thoughtful enough about having a big enough tent to bring everybody along, which, as you correctly point out, I'm not sure where the questioner went, I'm sorry. You know, when you have 50% of people actually disagree with you a priori, it is a really big job actually to figure out how to bring everybody along. You know, I have argued for the importance of articulating a radical vision and being ready to do the really hard incremental work of bringing people along and making the small changes that ultimately shift policies, shift economies, shift countries, and create healthier populations without losing sight of a really ambitious radical agenda. And I think that balance is actually quite hard to strike. And I think there is a danger of being so far in love with your own particular radical vision that you exclude others, and on the other side of being milquetoast and saying, well, this doesn't matter so much, I'm willing to compromise. And I think it is on us to find that place in the middle, and I think we have a hard time with that, reasonably, because it's difficult to do. So I'm giving you sort of a bit of a conceptual answer, but I do think we need to grapple with that conceptual answer, and then that could inform how we act on a day-to-day basis.
Well,
I'm just going to put in a plug for a recent issue of the American Journal of Public Health that has a number of papers devoted to public deliberation. I think that we, given the polarization and division in our society, this is one of our biggest challenges in moving forward, and finding a way to talk to each other so that in a respectful way where we can understand each other's point of view, I think is incredibly important. I believe this was the subject of a keynote at last year's APHA meeting, and I think it's really incumbent upon us in public health to try to learn how to bridge that divide, or else we're not going to be able to make collective progress.
Well, in that, I think we have something that does offer a big tent, and that is that everybody, I believe, values their health. And so for me, that outcome is something that ought to be a tent under which all of us can gather. And the fact that we're not doing too well really has to be acknowledged. That's what we're all here doing this afternoon. And we have to sort of galvanize a call to action to address it. I just read that about 10 million people have been stripped from the Medicaid rolls since the unwind began. About 2/3 of them are people who lost their insurance for procedural reasons, which means some share of them may have been eligible. That's a pretty narrow issue to talk about, even in states that haven't expanded their Medicaid. So I think that health ought to be something that unifies us, but I don't want to paper over the fact that we are enormously polarized. I personally believe that at the root of this polarization often is a belief among the population that sees itself as white, that they benefit from arrangements that have been damaging to us all. And I don't know how we'll get past this by sort of acting as though we don't have to grapple with racism, which some people think we shouldn't even talk about. And so that's where I get into difficulty with this idea that we have somehow to bridge a divide. There are some divides that shouldn't be bridged. The idea of the innate inferiority of some people is a divide that should not be bridged. And similarly, the notion that Indigenous people somehow got what they deserved is a notion that shouldn't be bridged. So what do we do with that? I guess I'm asking my panel in the audience for answers to questions that I'm not sure of the answer to.
Well, what the question was, how do we engage with people who have opposite political perspectives than we do? And so I teach my students to practice an elevator speech, something that's going to engage others. You know, you don't have much time, and they practice, they record, and then I tell them to use the speech around dinner time when you get a marketing call that's being recorded for quality assurance purposes. They won't hang up. And you can practice your speech there and get better and better at it. And you need to have a lot of killer facts at your disposal. So I keep a long list of these killer facts, and I practice trying to do it in front of you and in others to engage with people that you disagree with. And don't say they're wrong. Try and find their perspective and see if you can come to some common understanding.
Good afternoon. Thank you all for a very thought-provoking panel so far. My name is Jennifer. I'm the executive director of an environmental justice nonprofit in Houston, Texas. My question is, I'm curious, how do y'all see the impact of climate degradation impacting life expectancy, and how will it show up? Because air quality, carbon, fossil fuels are not an MMWR cause of death.
And I could take the first attempt at addressing that. So actually in the indigenous populations, we are seeing a lot of work in this space, and not just American Indian, Alaska Native, but really worldwide. And if we look at the issues in the circumpolar region and the Inupiaq populations and the changes to the ice, the sea ice and the wildlife, and it's really having a huge impact right now on subsistence living cultures. And we're seeing that play out. In addition to that, there's a larger movement looking at the mental and emotional health impact of climate change. And just thinking about it from my perspective and the traditional ceremonies we practice, and Lakota and other Northern Plains tribes, you have a Sundance, and global warming is actually having a huge impact on our ceremonies, that there's actually impact on how we can participate in our traditional practices. So I look at climate change issues and global warming issues really in a very holistic way. It's not just the physical planet that's being impacted, but it's affecting mental health, emotional health, and spiritual health and cultural practices. So I'm happy to see that there's some initial movement in that direction to look at things more holistically, but you're absolutely right. That needs to be a part of our curriculum. Even in medical schools, we need to be doing a better job at understanding the impact.
And I think the impact on measurable health outcomes is already becoming apparent. We can look ahead and worry deeply about its effect on life expectancy, but already in terms of disease-specific outcomes, we saw, for example, a recent paper in JAMA about the smoke from Canada causing an increase in emissions in New York City for asthma and so forth. Heat-related illness over this summer resulted in a documented increase in emergency room visits for people who are exposed disproportionately in communities of color and low-income communities. Studies that show that redlined communities, communities that experienced redlining in the 1930s and 1940s, are where the heat islands are. So I think we're beginning to see that data, but I agree with you that we need to develop better metrics so that we can document the climate-specific effects on health degradation.
Another part of it will be migration and the impact of the climate crisis on people leaving their land, including at our people arriving at our southern border. But I agree, we don't really have a cause of death that says this was related to climate, and that would be important to think through.
Thank you all so much.
Please.
Thank you very much for this panel. My name is Nancy Krieger, Harvard T.H. Chan School of Public Health and Spirit of 1848 Caucus. I'd like to come back to the critical importance that you've been raising of where social movements fit into this picture, but also it's not just social movements, it's who they're putting pressure on in terms of elected officials. And one, I think it's important that we be mindful, we've done work and others have as well, showing that between the mid-1960s and 1980, that period before, there was both decline in U.S. mortality rates and also a decrease in the inequities in those rates. Both are possible to have at the same time. And if we don't remember that and tie and look at what was going on with the activism of the civil rights movement, look at the activism that led to the EPA being formed, look at the activism that led to OSHA being formed, we forget that. And that was about social movements putting pressure on legislators. So I'm wondering, to make policies, make changes, and also begin to address some of the issues that are now been reversed by the deliberate backlash of the increase in market fundamentalism, AKA just go for basic capitalism. And I think that that leaves the question of, does everybody truly value everybody's health the same? Clearly not. And so I just would wonder if you can give concrete examples of either the social movements, different specific groups even, or which sectors you would want to be seeing public health people be more engaged with, but also if you have examples of elected officials that you see being responsive to pressures. Because it's both that our social movements don't just move in the abstract, they move to change things, and they move to change what the elected officials do. And then there's also the question of where that fits back to what our prior APHA President Chris was talking about around voting rights and around gerrymandering, about how do you even get those political officials in the first place? Who are they actually representing? And I mean, I understand the arguments that are being made that we have a polarized country, but I think we need to keep our eyes on the proverbial North Star.
All right.
So if you have examples, any of you, that are like inspiring, concrete, real, actionable, that would be very nice to share.
You mean contemporary ones? I
Yes,
mean,
like who to
right.
talk to now.
Right. I mean, you're absolutely right that we saw in the 1960s what we, you know, the Great Society programs all were the result of social movements, the civil rights movement, the women's movement, environmental movements. All led to a whole raft of legislation that have had an enduring impact for everyone. But I'm having more trouble. I guess the Affordable Care Act did extend health insurance coverage to more people in this country. We still have we saw the uninsured decline during COVID. The COVID experience might be one that we could turn to. It's reported that child poverty was halved due to the child tax credits and the other efforts that were made to protect people's well-being financially during the COVID pandemic. So we saw an enormous re-strengthening of the safety net with measurable outcomes like reduced childhood poverty, unfortunately, and reduction in the proportion of uninsured. But unfortunately, those programs are all being rolled back now. So anybody else have any?
I'm not optimistic, Nancy. I think I'm starting to sound like a cranky old man, but we live in a situation where the politicians you're talking about have as their top priority getting reelected. We've seen this in our daily news. They'll do anything to avoid losing from an election. They're driven by what their campaign donors expect of them and what they expect from their base. And I don't know what the most effective strategy is to get at those incentives to change their policy priorities. Presenting them with facts of the sort that we have in public health, epidemiology, and so forth, or presenting them with data on climate science doesn't seem to change policy choices.
How about the recent gains in the labor movement? I think that should inspire us all. The UAW, even, I mean, and the Hollywood writers and actors all showed what collective action can do.
Yeah, maybe just, I mean, the two that popped into my mind just sort of are both youth-led, which is Sunrise Movement, climate, around climate, and firearms. And I mean, these are, I mean, firearms, social movements around firearms in this country were essentially nowhere 10 years ago, and they're now much more forward-looking. Similar around climate, we heard the previous question. So I'm trying to balance. The pessimism, which sort of inherently is in the name of this panel, with optimism, and most of my optimism comes from the next generation.
Yeah, and I would agree with that. I'm hopeful with future generations, and every day this country is getting more diverse every single day. And in my own experience, being a medical school student in the 1990s and now teaching medical students in this current day, I see a lot more diversity of thought. I see a lot more acceptance of other peoples. I see, what I see anyway, is less discrimination and more acceptance. I'm hopeful for future generations. I think we're having a really difficult time now with our current political dynamics, and it's very frustrating. But I also see a movement of younger people that are wanting to move in the direction that you're describing, Nancy.
Yeah, I think we need to see action as the antidote to despair. So get involved locally on movements that work globally, and I could go on and describe some of my efforts, but that's what keeps me sane so far.
Hi, Mark Garevich from NYU's medical school. Really great to have this panel, and I want to, the title of the panel, I think, talks about the decline in life expectancy, and it says a public health emergency, and there's an exclamation mark. So that is the point. There's this disconnect between the scale, which is immense, of this as a crisis and our response. And so a couple of people have talked about the mobile, and even to Nancy's question, the mobilizing the political will, the public will to tackle this. And my question is around, is health and life expectancy a concept with the sufficient traction for that? And I'm skeptical at this point that it is. Combating structural racism with reparations, that's an issue. Reducing child poverty with a tax credit, there we go. And those, of course, would have spillover effects on life expectancy. Those are the policies, the changes that we all believe, I think, we need to do it. And so I just wonder, to the panel, to what extent should we be putting our energy and trying to galvanize around life expectancy and health more broadly, which clearly are important aspirations, and to what extent should we be going right for the thing itself, the underlying drivers of this change?
Well, I always say go upstream, and the Department of Health in Hawaii has a report that they published on social determinants of health, and on page 2 was a graphic of a mountainside, and down in the with a pass up there, a waterfall, a river coming out into the ocean. In the ocean were the chronic diseases that you'll suffer from if you're not already. On the shore were the personal behaviors. On the other side of the river was health care. Then around the waterfall were all the social determinants of health. And upstream of that were socioeconomic conditions. And the highest item there was political context and governance. So if we can somehow see that the political choices a society makes is really the most important thing we do, then we've accomplished something. But that's difficult.
I think Mark's making an additional point, though, which is the frame that we use. That because we are in the health business, we think health is the frame to use, but that may not be the most strategic. And we all know what the social determinants of health are. We all know the role of systemic racism. So if I'm understanding you correctly,
yes,
if we target those root causes, we'll be getting at the health outcomes we also care about, but actually dealing with the structural determinants
yes,
of the problems we're addressing.
If I may just add one thing to Mark's question, building. Now I'm sounding like Steve because now I'm being pessimistic. I actually think that I think we don't know, Mark. I actually think that if we thought we knew, or at least we thought we're heading in the right direction on communicating about health before COVID, if anybody's been paying attention in COVID, it should teach us that we actually don't know the first thing about how to communicate. And I actually say that not because I have any answers, because I actually think it's a time for reflection. I think Mary made a really interesting point to my earlier point about, how do we deal with what I would consider to be core values, non-negotiable core values? How do we actually hold those dear while also trying not to well, we're trying to bring along large populations. I actually think we don't know how to do that. I think we haven't, I think we have ideas, or people have written about it, people have thought about it, people have presented about it, but this is the time for us to rethink about how we advance the agenda. If we can all agree the agenda is a radical vision of a healthier country and world for all, where no one is excluded from health. That's our vision. How do we communicate so that we can bring people along there to get there? In my assessment, we actually have a lot of thinking to do to get there. So I think your question is just the right question. And for any students in the audience, I think there's a really interesting career to be had in guiding us how to get there.
I think this is a really telling question, so thank you, Mark. I guess I feel really struck by the decline in life expectancy and alarmed that it hasn't caused more alarm. So people in public health, and I'm honored to be on a panel with people who've gathered the data to show it, have been doing their best to sound the alarm. So have journalists. There's been a series in the Washington Post, the New York Times, the LA Times, but we have not gotten politicians to pay attention to this. One of the things that I always reflect on is that the Soviet Union saw a decline in life expectancy before its collapse. It was one of the early harbingers about 10 years before the dissolution of the Soviet Union. So I think politicians should be pretty worried. I subscribe to the Financial Times, the UK paper, just to get the graphics done by this young guy named Byrne Murdoch. He is a journalist. I don't know who he got working for him, but he put together data to suggest that there was a 25% chance that a 5-year-old today in the United States won't make it to the age of 40. Now that ought to really worry some politicians. So I just don't know why we haven't been able to make that breakthrough. Because to me, it really is a harbinger of, of bad things to come. So,
this side next.
Hi, thank you. My name is Taylor Lampy. I'm also with NYU. And I really appreciate the emphasis today on political organizing and politics as really important components of this conversation. But it makes me think a lot about the environments we work in as public health workers and how many of us are actually in environments that are hostile to political organizing, where we might get punished for union organizing or organizing for Palestine or any of these really political topics, and that we have to take our political work outside of work because we're constrained by funding constraints, the institutional constraints, and really just workplaces that don't want us to be political agents. So I'm just interested in what you think we can do as workers in public health to really be political in what we do. Thanks.
what you say is true.
Yeah. Yeah. And working in public health, working in the public sector, working for governments, it does tie our hands, unfortunately, in many cases, in terms of political activity. And that's just kind of the nature of the structure of things. So it's at least for myself personally, it's done on outside time, and I think that's just when we have to do it. But that's just the nature of working in the public sector. And it is frustrating that we have limitations on what we can do in terms of political activity and what time of day we're doing that political activity.
For those of us in academia, I think there's a little more freedom, but there is a tradition, at least in my generation, that politics has no place in scientific research. But I think those days are over. We're in a situation at this point where partisan affiliation and policy contexts are as strong a determinant of health outcomes as many of the classic social determinants. I don't think we can do our job in academic public health without addressing policy and politics as upstream drivers.
I would say the responsibility of an academic or an intellectual is to political issues. This was what the driving themes were in the 1960s, and of course quite a few academics got fired. I remember Bruce Franklin at my medical school at Stanford. He spoke out against the Vietnam War, and although a tenured professor, he was relieved of that. I think we have to take those steps.
We're all rather gray-haired up here, however. So.
Thank you so much for this panel. I'm Julie Kapp from the University of Missouri, and I am a big fan of your report, Dr. Woolf. I use it every year in my epidemiology class, and for those who have not read it, I highly, highly, highly recommend it. I would say in a lot of ways you can base your whole career off of trying to go back to what is said in that report and how to fix a lot of what is happening. And you've all spoken to this in a lot of from various angles, but it's so complicated, and so please help me as somebody that was very young in 1980, and for the folks in the room that weren't alive in 1980. When you look at the graphs, the U.S. was within the pack of other countries in 1980, and since then, all the other countries are increasing their life expectancy, and we are kind of going in our own direction, like Charlie Brown running off the track by himself. But our health care spending is so much higher, as you've already said. What was the specific policy in 1980 that dismantled all of this, that I feel like we're all spending our time today trying to fix what happened by a couple key decision makers back then? So what was the specific policy? And apart from just passing a whole bunch of policies today, because we can't go back in time, what would be like the two key things that need to happen? Is it universal health care? Is it dismantling incentives in Congress that don't help people? What two key things need to happen?
Well, what happened, I think, that Nancy Krieger and others have spoken to was the advent of neoliberalism or market fundamentalism. There was a piece in Business Week in 1974 preceding this that I like to quote. "It will be a hard pill for Americans to swallow, the idea of doing with less so big business can have more. Nothing in modern economic times compares in difficulty with the selling job that must now be done to make people accept the new reality." The selling job was very successful, and we were quite happy to lower taxes on the rich, so we had a huge wealth pump to give it to the billionaires, thinking that that would be better for us. And that's where we need to start with reforming our tax system and using the funds. Yes, universal health care, but for early life. Remember, there's only 2 countries in the world with populations of 1 million or more who do not have a national policy of paid maternity leave. One is, of course, the United States. We can't afford it. And the other is Papua New Guinea. So we get what you pay for, because roughly half of your health sitting in this room was programmed between conception and age 2, the first 1,000 days. We need to do something different in those days to make later life be a healthy one.
Right. When we say neoliberalism, what we really are talking about is the idea that the market was seen as the place to adjudicate our social values and to determine what was, what would survive as a policy. And it was accompanied by really reducing the state. You all remember, well, since you weren't alive, or this, the Ronald Reagan's pithy remark that the scariest sentence he'd ever heard was, "I'm from the government and I'm here to help you." So this notion that the government should be scaled back, that its regulatory powers should be reduced, and that sort of trickle-down economics would benefit everyone, were a whole raft of policy decisions. Since I've recently come from state government, I'm currently kind of obsessed with the rise of management consultants as our pals in government. That was another form of privatization that was privatizing core functions of a state agency. So all of that falls under this heading that we use as a shortcut, the word neoliberalism. But basically it says we let the market decide what's important. We're also, I want to, unbelievably, a plan for early childhood, a universal pre-K, had passed both houses and was vetoed by Nixon. The notion that we could have come to an agreement that passed both houses to have universal pre-K seems almost unbelievable now, but it did once get that far. So as somebody was saying, probably it was Sandro, when you do it once, you can do it again. So that's why everybody should pay attention to voting and voters' rights as well.
I'll just add one thing. I mean, I'm in agreement with everything that Mary and Stephen said. Milton Friedman, who was one of the intellectual architects of what eventually became this sort of this real extreme effort to deregulation, which preceded a lot of these things. He has this quote, which I'm not going to remember exactly, which from the 50s, where he says, "Our job is to generate ideas and to keep pushing them until the political conditions are such that our ideas are taken up." And, he and a number of other people kept at it for 30 years until Ronald Reagan was elected and a lot of things changed. And I guess I use that quote because, of course, it doesn't all have to apply to that set of ideas. It can apply to many other sets of ideas. And I actually think the reason we have these conversations, the reason that we think about these things, the reason we put these ideas out there is because it is important to do so and to keep pushing until the conditions are such that we can change the things that actually need to be changed.
So we're running out of time. We have 3 minutes left. Let's take the last question, and then we're going to have a coffee session outside so we can gather around and talk about it more. So one last question, and then quick closing comments from the panel.
I will be very quick. Gratitude for a wonderful discussion. So at this point, what do we do to change the narrative and say health over profit? What are the things that needs to be done? Because sometimes I look at where health is lost also, some groups, some people are getting rich out of it. And where health, at least pre-COVID, was better